Well, hey everybody, it's great to be here. I wish we were outside, but it's great to be here with you. It's always an honor. They maybe give me a little bit extra time because they know it takes me a while to figure out the technology. So,
take your time to hurry up.
All right. Okay. I'm going to do that.
You let us know. That's all.
All right. Thank you so much. There's my Iowa slide, and some of the things we're known for in Iowa. I should have put Iowa women's basketball. I did. Right? Caitlin Clark, and all the other tremendous Iowa ladies basketball players. And let's see, so I'm doing this right. Oh, there we go. So here's our great PRRT team, some of whom are here, and Dr. Chandrika just gave a great talk, and it's just been an honor for me to be part of this group for many years now, and of course the great Tom and Sue Odoricio should be on here. They're forever. Many of you may know Tom and Dr. Tom and Dr. Sue. Dr. Sue's retired, and sadly Dr. Tom is no longer with us. Passed away a couple of years ago. I also see we have the best endocrine surgeon in the country, Dr. James Howe, and he's not on the slide. All right, so let's go. All right, so here's my radionuclide targeting slide, and the whole deal is we've got that cancer cell, and let's see here, cancer cell here, and then the targeting molecule, and then we have this, we call it a chelator, and it's a molecule that grabs hold of the radioactive moiety, and it can be gallium. You saw Dr. Chandrika show you some gallium PET images, or it can be lutetium, and of course that's Lutathera. It turns into Lutathera, and you're all familiar with Lutathera now. And then of course we have other agents. Copper-64 is another PET imaging, turns the molecule into a PET imaging targeting molecule. And we'll talk a little bit about actinium-225, and I hope I forgot to put lead on there. So basically talk a little bit about alpha particle emitters. That's one of the areas that I'd like to update everybody today, a little bit about alpha particle radioligand therapy, or alpha particle PRRT. And just many of you know this, and so it's just a bit of a refresher. Lutathera, there's this high energy electron, the beta particle there, that gives rise to the cancer tumor cell killing that goes on. And the actual targeting, if you're interested, are these two amino acid substances at the tip of the molecule that really represent the part that grabs on to the tumor cell receptor, the somatostatin receptor. We'll spend just a minute here. So a little bit of a busy slide. Didn't come through quite as I'd hoped, but the idea, we've got the beta particle, and then we're going to talk about the alpha particle treatments and how each affects the DNA of the cancer cell and leads to the eventual death of the cancer cell. So the NETTER-1 trial. Everybody, I think, is very, very familiar. It was published in the New England Journal, 7 years ago. So, and then of course the trial itself was conducted for a number of years prior to that. I think the University of Iowa may have been, and really the VA as well, may well have been the major patient contributor to this trial that led, the results of which led, of course, to FDA approval of Lutathera. and I hope it's big enough for you to see. But here are a couple of the survival graphs that demonstrated the advantage of being treated with Lutathera. That's the group along this line, and then compared to being not treated with Lutathera. And this is progressive disease over here. And did you see how I seamlessly, Dr. Howe didn't think I could do this. You see it moved from one side to the other. And and of course, this is the overall survival, and there's a definite difference. And so Lutathera was a major breakthrough for treatment of these types of tumors. But much has happened since Lutathera was approved. There you get an idea of the progression, the difference in the progression-free survival at 20 months back at the time this was published. The lutetium group at 65% compared to the 11% in the control group. This was one of our first patients that was that participated in the NETTER-1 trial, who was treated with Lutathera. And I think I heard Dr. Chandrasekharian refer to the Octria scan. So back in 10 years ago, we weren't doing gallium PETs, we were doing Octria scans. This is actually a kind of a tomographic Octria scan that matches up with the CT scan here. You can see the T's mark the tumor sites on the CT. And then here is the patient's CT scan and the liver after 4 cycles of Lutathera. And you can see how much better and healthier the liver looks. These sites here and here marked with the T are no longer, well, mostly they're not even visible. There's a little bit of residual disease there as well. But that was one of the very first patients. And I think we're going to pass on the overall response rate. A little bit busy. Maybe I've got a little too much going on in this slide, but we'll go through it because it's important. It's the NETTER-2. So there was the NETTER-1, and then Novartis said, hey, well, we all need to look at patients with higher grade, the higher grade 2 and grade 3, and Dr. Chandrika talked about the Ki or the Ki67 that distinguishes these tumor grades. So the NETTER-2 said, well, all right, let's see what the higher grade tumors do when we treat them with Lutathera. And what we see, and this actually is fairly early, I think this was just reported at a recent conference, and I'm not sure it's actually been published in a full manuscript, but you can see that for the control group, the median progression-free survival was only 8.5 months in these patients that had the high-grade tumors, whereas the group treated with Lutathera had a much longer median progression-free survival comparatively. So right now, when you look at as a total group, all the patients that we treat with PRRT, lutetium PRRT, there's about 20% that just don't seem to respond very well. In many ways, we see we see about 80% that do respond, and now that includes individuals that we sort of call stable. But the studies since NETTER-1 have demonstrated that if you have stable disease, that is the CT scan shows that the tumor stops growing. If you have stable disease, that the outcome and prognosis is really very similar to individuals where the tumors shrink on the CT scan. The bad thing is when the tumors continue to grow on the CT, and that's this 20%. of non-responders that we need to, number one, figure out how to identify. Because, well, if you're not going to respond to the treatment, there really is no value in delivering this particular type of radiation therapy. So we have looked and continue to look at a number of ways to distinguish those patients that will respond well to PRRT from those few individuals that don't seem to respond to PRRT. And you know, we look at on the gallium PET or the copper PET, the SSTR PET, we look at now, and I'll show you a study or two, we see whether the uptake, the targeting of the tumors on the PET scan predicts those individuals that will respond to Lutathera. It kind of makes sense that if we see on the PET scan that the tumors are being hit by this molecule, then the same molecule, when we put lutetium onto it, ought to be effective in eliminating or killing tumor cells. A number of other ways that we're trying to determine whether or not individuals will respond are depicted on this slide as well. And you can see, for example, FDG, which does, it looks like, give us some indication whether tumors are likely to respond. And then there are a variety of other things we're looking at as well. So let me, along those lines, the Lumen study that I'm going to talk just recently, very recently published, was a prospective phase 2. Everybody got 4 cycles of the Lutathera. The usual, you know, every 10 to 12 weeks, pretty standard. And what the investigators did is they looked at the radiation dose to the tumor. And so we'll talk a little bit about the actual radiation dose to the tumor. And that's different than how much we put into the vein when we do a scan or a Lutathera treatment. So, and this idea of dosimetry has been around a long time. At Iowa, we've been big believers in the idea of using dosimetry to predict both toxicity from a particular radioligand therapy as well as tumor response. So that this group did measure the tumor metastatic dose that was delivered by the lutetium treatment. And they also looked at a way in which they were able to determine sort of the total tumor volume that expressed the SSTR on the tumors. And they said, well, let's see if either and or both of those help to predict the patient outcome. So here's a couple of figures from their very recent publication. And what they found is that if you look at, and sort of here's the key, and it's a little bit of a nuance, but it's important. You know, for years we were used to looking at how much radiation are we giving to the sort of the hottest tumors, the tumors that are brightest on the gallium PET scan. But now more recently, in recent years, studies from a variety of groups are telling us, hey, you know, if we're really going to predict the outcome from these radioligand therapies, whether it's in this particular type of tumor, the neuroendocrine tumor, or other types of tumors we treat with radioligand therapy, we want to look at the dose that's delivered to the lowest uptake tumors, the tumors that have in the body, because, you know, many times there are quite a few of these metastatic sites. We want to look at, what's important is to look at the tumors with the least amount of uptake in order to predict how well the individual patient is going to do with the treatment. And in fact, this study along those lines, and we've kind of been wondering about this for a long time, so it demonstrated that if you look at the tumors that have the lowest uptake on the scan, so the lowest radiation dose to the tumor, but those tumors get more than this 35 gray. So gray is just a measure of an amount of radiation, and 35 was kind of the cutoff that this group found, and it sort of makes sense. I mean, with other tumors we've known for a long time that if you get into that 30 to 50 gray region, that might be where we're starting to see response. And again, keep in mind this is for those tumors with the lowest gray. And indeed, the authors did see a separation in the red curve. Those patients that didn't get 35 to the lowest treated tumors, lowest radiation exposed, compared to those that did, there was a clear separation in the progression-free survival curve. It also, we've asked the question as well, can the gallium somatostatin receptor PET help us in determining who's going to respond? And by the way, this is after, I should say, this measurement of the remember there's 4 cycles. So the measurement of the radiation dose here, it's based on the treatment the effect that we see on the scans right after the first cycle. So this kind of tells us right away. And you might think, well, hey, all right, so if you do a scan early on after that first cycle, then it looks like some of the least targeted tumors are going to get less than 35 gray. Well, maybe in the subsequent cycles, we ought to be increasing for those individuals the amount of delivered radiation so that those least tumors can have a better chance, and the patient has a better chance of progression-free survival improving. This is I'm just going to real quick, this phenomenon they also demonstrated in this study. We've seen it for 20 years. And I thought I'd just mention it. It gets some play over the years, but we kind of think it's important in thinking about the future way in which we want to use PRRT type treatments. But oops, I didn't want to do that. There. So see the first blue. So here's the absorbed radiation dose in the tumor along this axis. And then these are the cycles. And what we've known, and what this group just depicted again as a bit of an aside, was that the first cycle, the tumors get the most dose. The second cycle, a little bit less. Third cycle, a little bit less. Fourth cycle, a little bit less. So we think that, hey, we ought to be exploiting that feature of the PRRT effect as we think about future ways to utilize PRRT. Again, biggest dose to the tumor first cycle, least dose to the tumors in the fourth cycle. And it's informed the way that we've designed our studies at the University of Iowa, where in fact we're interested mostly in delivering our treatments in 2 and maybe 3 cycles total. All right, we're gonna move on, and so here's another study, and I'll mention it here briefly. And again, they didn't actually measure the dose to the tumors, but this SUV thing that you may see in your PET report is a bit of a poor man's indicator of what the dose to the tumor is likely to be. They're related, but not real close. And what this study found was that when you look at the SUV, which is just, how hot is that tumor looking on the gallium or copper PET scan, if you look at the patients with the higher SUV and you compare them, now the red line, the red survival curve is the lowest. And then again, by the way, these investigators picked up on the same concept as what we talked about just a minute ago, and that is, what may really predict survival is not how much we hit the highest tumors with, but how much we hit the lowest. And so this is, again, keep in mind, these are the lowest uptake tumors, and if your uptake in the lowest uptake tumors was pretty high, you did better as a patient than if your uptake was low. Now, this study also included a consideration of the total somatostatin receptor positive tumor volume. Won't get into it too much, but we've also known this for a while, and it was borne out this, and that is patients who have lower tumor volumes respond better to the PRRT than if we have the extensive. It doesn't mean the patients don't with extensive disease, but the likelihood, probability is better. But the most important thing I want to show you was the relationship to the SUV, which is related to the tumor dose. I show this, I like to show this. We have a great Irishman in the audience. I don't know, maybe he's not here at the moment, Dr. Dillon, but my daughter is now an Irish citizen. I have a great son-in-law from Shrewell, a little town in Ireland. I'm an enormous fan of the Irish people and their brilliant attitude that I think is depicted nicely in this slide. As you can see, they're panicking. There's this intense panic taking place. I think a very wonderful life's philosophy. Okay, so, all right. Now, this was a study again that looked at, we're going to look at the dosimetry, the radiation dose issue from a little different vantage point here. What this group did, and we'll look at these two figures in a minute. What this group did is they said, all right, let's give everybody an amount of radiation that leads to a maximum radiation to a normal organ that we're concerned about, which is the kidneys. And then let's compare it to just giving everybody, you may know, the standard, everybody gets all 200 millicuries times 4 cycles. Let's compare. Let's see if there's a difference. And indeed, as you know, we have suspected, and others have shown as well, if you take each individual patient and you say, all right, let's give enough of this Lutathera to expose the kidneys to the maximum level that they seem to tolerate before the kidneys start to cause a little trouble, will the patients do better than how we're currently treating across the country, 200 every 4 with 4 cycles? And yes, indeed, if you look at the different overall progression survival curves, you can see the blue curve is the kidney here, the kidney got the maximum that it could tolerate versus, everybody just got 200 millicuries. And again, those patients that were treated to a maximum tolerated amount did better. So we hope that as we go ahead in the future, move ahead in the future, we're going to combine this idea of, well, let's treat to the maximum that the normal tissues can tolerate. And at the same time, let's look at getting those, remember the dose to the tumor, that 35 gray. Let's also incorporate a consideration of the radiation dose to the tumor with the lowest uptake in designing our paradigms for this particular therapy in future treatments. Okay, and I know I'm probably way behind. How far behind am I? I have 10, few minutes, okay. Well, all right, so I really wanted to get to alpha therapy. So alpha, we believe, is sort of the next step in PRRT and radioligand therapy. And then, of course, here I've got a slide with antagonists. So it turns out there's somatostatin receptors on the tumor cell. And then some of the receptors we call agonists. So it means they would be stimulated. And some of them we call antagonists, which means that the somatostatin sort of destimulates the receptor. And there, in some cases, what we've found, others, not us locally, but for a long time we've actually known that some patients, so here's our gallium, dotatate, dotatoc, this is our standard gallium. Some patients won't show the usual uptake targeting with gallium, but if you take a somatostatin receptor antagonist, Little different molecule. Well, all of a sudden, you can see how dark the liver here is. This LM3, this is the antagonist scan. This is our usual gallium agonist scan, just the gallium PET. But in this particular case, it's not common. But see how much better the antagonist does for this patient, not everybody, targeting the tumors in the liver. Okay, now maybe I'll get to the alpha. I'm going to skip that. Alpha. So this is my alpha particle slide. I think this is actually a picture of a supernova. But alpha particle, lots of energy are released. The alpha particle delivers orders of 10, 100 times more energy to the tumor, and we hope in the nucleus of the tumor, than does the beta particle. And so it's an exciting new way, and some of you probably have heard about, well, and I'll mention the fact that, so the DNA we got the two strands of the DNA, and when we use a beta particle, the beta particle typically breaks one of those strands. Well, many tumor cells can come along and repair that single strand break. And so sometimes the PRRT isn't effective at killing the cell, the beta particle. But alpha knocks apart both of the DNA strands, and the repair process becomes much more challenging for the tumor cell, and we get a much higher amount of tumor kill for a particular alpha particle shot through the cell as opposed to the beta. I'm going to skip that. This slide, and I'm worried that it's not showing up real well. It kind of gives you a sense of the excitement that you might have. This was a patient that was treated with this, it's a little hard to see, this actinium-225. So that's the alpha emitter, and it's on the same targeting molecule that we have with Lutathera. It's basically Lutathera minus the lutetium plus actinium. And if you look at the red arrow here, see this big dark area? That's one of the tumors in the tip of the liver on the gallium scan. Look at the dates here. This was 2012, and the patient received 4 cycles of the actinium PRRT, and look at what happened to this big dark. See it go away? There's another arrow, just another date and time. These scans after the alpha PRRT, and then look here. 6 years later, that thing is just gone, and look how slowly it went away, which is also a feature of the effect of PRRT, is that it slowly kills the tumor, sometimes over years. And here, look, it's not there, even 6 years later. What we do see, and what did happen here, but this is pretty impressive. Look at the tumor cells, or the tumor sites, the dark sites go away. What we do see, because in this case the patient did recur, is that we'll see recurrence at not often at the same site that the tumor was originally at, but often at completely new sites. And we've sort of been seeing this phenomenon for 20 years, going way back to the yttrium 90 days. And actually, Dr. Tom Odorisio said, hey Dave, I think what we're seeing is that the original tumor sites are effectively treated, but how are we going to handle the development of these new sites that eventually lead to the recurrence of the tumor? And all right, so let's look just briefly. I want to show you. This was a trial where it was a bigger trial, and you can see, there were 57. Well, maybe it's going to be hard to see, but there were 57 patients with prior PRRT Lutathera, and then there was a group that had not received Lutathera, and they were all treated with the actinium DOTA molecule. And then what the authors found, and we'll just go here, that the response rate was really good. particularly if the response rate to the alpha, the actinium, was particularly good, especially, this curve here, especially if individuals had responded well to the prior beta PRRT, the Lutathera. And that's kind of one of the key findings of this study. And so right now, there is an ongoing trial called the Action 1 trial. We have it open here at the University of Iowa. And the Action 1 trial, you know, the treatment agent is the actinium dotatate. Again, it's basically Lutathera exchanging lutetium for actinium. And then the idea is we look at the effect of the actinium compared to a smaller group. I think it's a 2-to-1 rate. Is that right, Dr. Shadrika? 2-to-1? Is it 1-to-1? 1-to-1. So the best standard of care compared to the actinium dotatate. And so I wanted to let you know that was open. And number of sites, I don't have a list of the sites across the country. I think there's about a dozen. And then, you know, in wrapping up here, I wanted to mention this. So lead-212, I think, is one of the really exciting alpha, along with the actinium, there's others, agents that we're particularly focused on at the University of Iowa. And Dr. Zimmerman published a few months ago in Journal of Nuclear Medicine, hey, is lead-212 really happening? And there's so many issues that have been involved over the last decade with trying to bring this alpha particle lead-212 agent to the clinical trials, but we're there. And at the University of Iowa with our team, we have a phase 1 trial open that I'll briefly mention. There's another phase 1 trial that was opened with this lead-212 PRRT. This was one of the early abstracts from that group, and it's always exciting to look at the PET scan before treatment, and you can see the dark, the black tumor sites here before the alpha lead treatment, and then look here afterwards. Those tumor sites have just melted away on the scan, and then subsequently, this group began a phase 2 trial. It's currently open. It's available to patients. The phase 2 is for individuals who have either been or not been previously treated with PRRT. And so that trial is open and ongoing. And then, what do I have finally here? Oh, this is so that group has published results from their phase 1 trial, and one of the and this is going to lead into the last slide here, but it's going to segue into our trial a little bit. One of the concerns that we have, you know, we talked about dosimetry, and you know, the kidney is one of the organs we're a bit concerned about, even with Lutathera, the lutetium, although kidney toxicity is really quite rare with lutetium. But if you look at the results published by the group here, they found that there were a few patients that after some months developed some pretty serious renal toxicity. And this has been a concern for a lot of us for a number of years. And along those lines, a few years ago, probably been 5 years in the works, we began a trial. It's funded by the NIH, and here at the University of Iowa, our PRRT group. And what we do, a little bit different. We say, well, not everybody's the same. Some people's kidneys need to be treated a little bit differently, a little more gently. Others can tolerate more. And so in our trial, and these numbers may not mean much, but our cohorts of individuals are treated with a knowledge. We do some scanning, and we obtain some measurements of the radiation exposure to the patient's kidneys, and so each patient we treat different, and some people we say, all right, we can give more of the radiation and the patient's kidneys should tolerate it. Others we have to give a little bit less. And we're in this phase 1 trial basing our treatment individually on what the patient's kidneys we think can tolerate in terms of actual radiation dose. So it's a pretty distinct difference. It's not that we're unique in this approach at the University of Iowa. This really is an approach that for probably 15 years many of us have felt was the kind of the more sensible way to utilize these radioligand therapies, but there's always a little bit of a challenge. You know, the academics we kind of think this is the best way, but in industry they kind of look at this as maybe a little bit too complex of an approach. So there's been a bit of a tug of war for probably 15 to 20 years, but I think the move is more toward these individualized dosimetry-based trials in trying to optimize the way in which we use these radioligand PRRT therapies, in this case an alpha therapy with the lead-212 agent. So I think, oh well, I'll just show you real quick. This was our first patient, and you might say, well, okay, I see that study on the left is, you know, it's got very distinct, very, very obvious kind of uptake levels at the tumor sites. And the study on the right, it's true, it looks a little fuzzier, a little less distinct, and the study on the right is obtained with the lead. It's a lead isotope of the 212, lead-203. Won't get into it too much, but what it lets us do is, again, with the lead agent, predict how much radiation the tumors and the normal organs are actually going to get from an administration for an individual patient. And it does vary a great deal from one individual to another. And with that, thank you very much. It's always a pleasure to be here with patients. And we can, I guess, do questions later is how I'm seeing it. Okay.